everyone. Really good to see you. Please, I can see, somebody just raise your hand if you can see me. And if you can hear us. Yeah, good to see you, Gabby. Thank you so much. So thank you everyone for being here today. It's such a beautiful, beautiful opportunity to just see all this come to life. And I know I have journalists on the other side who are wondering, what is this journalists doing here, sitting in the middle of what you would call experts and scientists and researchers and people who have been just dedicating their time to doing this Born Too Soon report. Yes, I'm a journalist, but today I'm sitting here because in the last couple of months, I have had the honor and absolute privilege to sit and see how a report comes to life. I can attest that it's a lot of work, it's a labor of love, it's giving birth to a baby, which we'll be talking about today. So yes, my name is Mercy Juma, and today I sit here as the co-chair of the Advocacy and Comms group that worked on the Born Too Soon report that we are launching today in this global media launch. So you all have a front row seat and a first hand to get the details about this report, but the rest of the world will see and hear about this report tomorrow on the 10th of May through your stories. And yes, we are in Cape Town. There are some journalists coming in. Really good to see people who I haven't seen in years because of COVID. So what are we doing here today? We are looking at a report called the Born Too Soon Decade Action on Preterm Birth. Why is it called the decade? It's because we are looking at 10 years since the first Born Too Soon report was launched. That was 2012. And funny enough, the people that are sitting here with me, who I will introduce a bit later on, worked on the first report. So it's just really beautiful to see how the last 10 years have been just checked, where we've stopped, what needs get more energy and more investment. And that's what we are doing today. So the first Born Too Soon report, the 2012 one, really looked at maternal and newborn health more broadly, but face of SDGs. That's right. So today we are the decade edition of that report and analyzing how do we go from here, looking back and looking forward to the future, the next few years. What do we have we gotten right? What we need to go more in? And for I preempt anything, because like I said, I had a front row seat on seeing how things came up. Please allow me to introduce the people who are here. I have Helga Fogstad, Wonder Woman, Power Woman. She's the executive director of the Partnership for Maternal, Newborn and Child Health. This is a constituent of the WHO. And then to my left, it's Professor Joy Lon. Professor Joy Lon works for the London School of Hygiene and Tropical Medicine, but Africans in the house, let's note the name London fool you because she is African to the core. She was born in Africa, has done a lot of research on Africa. And if you have any questions on what the data looks like are preterm birth on sub-Saharan Africa, this is your woman. This is the lady to go to. And feel free to request to have your interview or any other that you may be able to use in the next few minutes. And then I also have Dr. Mahia Salim, Jirani neighbor in Swahili. He's from Tanzania. I'm from Kenya. So my sister, really good to have you here and really good to see you in this movement. Nahi is the works with the Newborn Essential Solutions and Technologies Programs Next 360. And then, sorry, ladies first. Okay, so we have Bo Jacobson, and Bo works at the division. He's a division director of maternal and neonatal health, FIGO, International Federation of Gynecologists and Obstetrics. So straight into what this decade edition report looks like. Professor Joy Lon.
Oh. Merci, Asante. If we could have the slides, that would be fantastic. So as Mercy said, I'm I'm actually a Ugandan. I was born in northern Uganda, and it's my privilege here on behalf of the large team that have worked together on this report, if you could go through to the beginning of the findings, to summarize briefly for you what is a 110-page report. It may be about maturity, but it's not a tiny report. And if we go to the next slide, I want to tell you what's different about the report. So on the left-hand side, you can see the report that came out in 2012. At that stage, that was our first ever preterm birth estimate around the world. This new report, we've looked back over the last decade, and the report has three powerful ingredients. First of all, we have new data on preterm, on survival, small babies, and I'm sorry to say big numbers that unfortunately haven't changed very much. We will give you some numbers. But there are other powerful ingredients in this report. There's also the people. So one of the things that really resonated in the first report and is even more powerful in this report, I think, especially thanks to Mercy, who has brought her journalist skill into these stories, is that the story of born too soon happens to every family, 1 in 10 families, babies around the world, every family in every country. High-income countries are also strongly affected by this. And it's not just the moment of birth, it can be a lifetime story of effect. So that human side is critical. And I would like to salute Partnership for Maternal, Newborn and Child Health. They have more than 1,400 organizations now, have been a critical convening, because to address this issue, we need many different angles. The parents, data, the scientists, the healthcare professionals have been a very powerful part, because we definitely need not just moment, but movement. So these are the three ingredients. I will give you some of the findings. So we move to the next slide. The 5 top findings, each of which has enough for a whole article, so a headline for each. Big numbers for small babies. And they really do matter. It's not just advocacy for babies. This is top of the global burden of disease. Number 2, the preterm rates. These are flatlining. So in looking at the progress, it's actually a major message that we haven't made progress. And then we have a third message here that is different, I think, to 10 years ago. We have seen COVID, we've seen conflict, we've seen many things that have threatened us. And each of those things that threaten us play out strongest for the most vulnerable. And what is more vulnerable than a baby or a preterm baby? So there's really a lens on this that is critical. And then we have a very positive message. There are things that have changed. This is opportunities for faster progress. We end with 2 tracks of progress. We must do more for prevention, and we can and must also do more for care, especially for those countries with the highest mortality. So we're poised for action. If we go into the numbers, next slide. So around the world, we have a preterm baby born every 2 seconds. And shockingly, every 40 seconds, one of those preterm babies dies. And this is the top cause, not just of neonatal deaths in the first month of life, but of deaths in the first 5 years of life. In high-income countries, this is the top cause. In the UK, this is the top cause of deaths in the first 10 years of life. And for the whole of your lifespan, this is actually the single largest contributor to loss of human capital now, and shockingly the same in 1990. So this is not just special advocacy. This is higher than non-communicable diseases, than cancers, much higher than AIDS. It's not that AIDS should have less attention, but this needs more attention as well. If we come to the next slide. So what we see, and this tells us we must act. Yes, indeed, this slide shows us the detail around the world. So the darker purple you are here, the higher rates of preterm birth. We measure rates of preterm birth, 100 live birth. They all happen to stillbirths. This is just measuring live births. So countries with the top highest rates, Bangladesh, Malawi, Pakistan, with the highest numbers, and this is driven also by numbers of deaths are shown here. And these are from WHO new estimates that have been cleared with extensive country consultation with each of these countries. So this is important. If we move to the next slide, I want to show you the time trends for these preterm births around the world. So what you can see on the left, which is such a flat line, it looks like a flag rather than a graph going down. What you can see is the total global number of preterm births, which is now at 13.4 million in the year 2020. And this is just really, there's few things in the world that look like this. No change in any region and no change globally. So this is a problem of slow progress, not just in low and middle income countries. So there are about 5 countries that have reduced their preterm birth rates by about 5% in the last 10 years. That's 0.5% per year. So clearly, this is utterly critical message. We need to do more. We do have things we can do, but we also need more stability and focus on this. We asked, do we need a target? We didn't set a target, but this is an important discussion. If we go to the next slide. So what does this mean in practice? Well, one of the reasons that we have not progressed as we should have done, despite having things that we can do, is because of some of these challenges. So for example, for climate change, we have more and more data to show that climate change is a driver of preterm birth and also of stillbirth. This is critical. And we have experts who would be able to talk to you more about this if you're interested. We want to flag that of the 10 most fragile countries in the world, they have the highest preterm birth rates. About 1.2 million babies are born just in those 10 countries who are preterm. And Mercy has been reporting a lot from South Sudan. That is also included there. So this is important. It is part of our equity and human rights agenda that our health systems and beyond take the most care for the most vulnerable. So if we go to the next slide, item number 4. Here we have looked very carefully at what has changed in the last decade that actually gives us an opportunity to go faster. And we would flag that there are some countries that particularly are starting to make progress for better care of small and sick newborns, rapidly progressing countries, including some particularly in South Asia and Southeast Asia and Eastern Europe. And we need to do better in Africa. We must run faster. So there are also new guidelines from WHO, particularly around things like kangaroo mother care, that give us great opportunity for change and also for enabling women in the empowerment of looking after their own children. So we're poised and we have these ingredients that could save millions of families from heartbreak. So if we go to the final finding is really how we move forward in action. So what you can see here is 2 tracks. To change this, we need to both prevent preterm birth, and then we need to do better in looking after women in preterm labor and their babies. So if you look around the world, with the flat rates for preterm birth, a lot of the focus has been on improving care. We need to do both. We need both tracks. We must do better on prevention of preterm birth as well as care, and we must close the care gaps. So if we go to the next slide, there are things that we can do on prevention of preterm care. Women's sexual and reproductive health is under threat in many parts of the world. For countries that have enabled women's choices for family planning, this is critical, especially amongst adolescents and older women. Infections in pregnancy, so for example, malaria in pregnancy is something we have solutions for. Syphilis in pregnancy, we've known for 30 years, we're still failing to operationalize it. So there are places here maybe also where we could be doing more harm than good. So the epidemic of cesarean section around the world is contributing. So there are important things for us to think about and learn and act on and use the evidence. And we would flag a new thing in this report, a very strong focus on intersectoral nutrition, education, and climate change. So if we come to the final slide, We must do more on prevention, but we are also facing 13.4 million babies who need care now. They can survive, and they shouldn't die just because maybe they're born in a country or in a setting or in a family that has less access to care. Every child should get that same right. And we have more in our hands now than we did 10 years ago. The science on kangaroo mother care has advanced. We know that to reach the Sustainable Development Goal for newborn survival, the first time we ever had a goal, and in fact, it came from the Last Born Too Soon report. We know that these babies also need respiratory support and more preterm care. And I would flag Dr. Nahia Salim, my sister here, who's an expert working on this across the whole of Tanzania very ambitiously to bring this care to every baby in partnership with the government. So I would like to land there, those 5 findings: big babies, big problem just for small babies. And yet we have big solutions in our hands. We have things that we can and we must do. And importantly, we have a big partnership here that we are calling for major change, not just in the next decade, but in the next 2 years. So I pass back to Mercy with thanks.
Thank you, Joy. And just
Microphone.
yeah.
The microphone's gonna be here.
Okay, all right. So let's just pause there. Go back to the last slide, Joy. And I'm trying to simplify that the survival gap. Over 90% of extremely preterm babies born in high-income countries survive, and then 10% in low-income settings. So if I simplify this, we're basically talking about 9 in 10 babies surviving in high-income countries who are born extremely preterm, and the reverse is true. 9 out of 10 don't survive, die in low-income countries. I mean, we do not talk about this enough, and that's a really, really sad statistic to look at. Now, please, if you have any questions for any of our speakers, put them on the chat, use the Q&A function. We may not have all the time to answer the questions, but there are a group of people who are looking at these questions, and definitely they will get back to you. And Kathy Bartley is also available for you to get all your queries, all your requests for interviews, or anything that you need addressed in relation to this report. Now, one thing that really has stood out for me in the creation and coming up of this report is the inclusion of the parents and the human interest stories. And, just realizing that behind all these numbers, when you talk about 1 in 2 babies, or in every second X number of preterm babies are born. These are statistics, but there are faces there, and it's so beautiful to see these faces. And that's why it's just imperative that we hear from a parent today. Gabby is from the USA. I had the pleasure of meeting Gabby before, and Gabby, thank you so much for joining us. So Gabby and her partner Jerome lost their baby, who was born stillborn and preterm at 27 weeks. Gabby, please, welcome.
Oh, thank you. I'm not sure if you guys can see me, but definitely it's a blessing being here, because I get to not only talk about Jillian's story, but hopefully bring awareness about, the impact that it causes for a parent. Summarize the story. Can you guys hear me okay?
Yeah, sure.
Okay. It was my 3rd pregnancy, so I was kind of new, what to expect. But there was something wrong. The prior weeks before that, I was leaking clear fluid. I was rushed to the hospital. They didn't really do any testing. They told me it was a yeast infection. I told them that I had no symptoms besides the leakage. They just sent me home and said to just go take Monistat over the counter. And sadly, a few weeks later, my son passed away from prenatal onset GBS. And I had no idea, what to expect on the way to the hospital. I was bleeding and I had lower back pain. So I kind of knew I was in labor, and I was holding on to hope. I kept thinking, okay, my son's going to be stillborn. He's viable. And only to get to the hospital to hear that there is no heartbeat. And this is how everything started, with the lack of support. My husband and I at that time, walked in pregnant and walked out empty-handed, and we had nowhere to go. There was no number to call. We felt like we were the only parents that had ever lost a baby, and that feeling alone inspired us to start a foundation in Las Vegas to help families that endure this tragic loss of a baby. And so in my son's honor, we started Jalen's Gift Foundation. And we've been doing this for almost 11 years now. And I can tell you that we work with 11 hospitals here, and we still average 1 to 3 stillbirths a week. So and these are babies that are 20 weeks and above. We do get a few that are miscarriage. We had no idea that it was this prominent. We thought it was just one, but within 3 months of starting the foundation, we were bombarded with phone calls and families. And we still average about that. So it's a big problem here in the US as well, you know, being that we're such a United States, there is still not a lot that can be done. There's not a lot of research, a lot of data collection to the causes of preterms stillbirths. Some of them are unknown. A lot of families that do autopsies do not get answers. So this is a kind of brief story that unfortunately there's not enough vital collection out there, records to really know why there's so many stillborns and preterms. And unfortunately, I kind of say that the majority are Hispanic here as well, and African Americans. My husband and I at that time, you know, we're both educated. We have master's degrees. We live in a regular high income household at the time. We took care of prenatal care, so it doesn't really discriminate. And what we have hoped to expand now is definitely focusing more on the father's grief that they experience the loss too. That's kind of our main goal for this year, and continue to reduce the preterm, you know, stillbirths and preterm babies. So just thank you for allowing me to share about Jalen. I'm excited that my son's story is now being, you know, in Africa and being spread through our story. We have been able to help many families. And I remember holding him in my arms and telling him that I was going to make a life for him and that he would not be forgotten. So thank you for allowing me to share my son's Jalen with all of you. And if you have any questions, just let me know in the chat.
Oh, Gabby, thank you so much. Thank you for sharing your story. And I remember when I was talking to you and Jerome, your partner then, and Jerome said something that, you know, when he went to hospital with Gabby, and then the child, Jalen, was handed over to them, and the first thing that Jerome was told was, do you want to bury him or cremate him? Those are the first words somebody ever said to him about their baby. And those words have stuck in his mind, and he is really trying to figure out how to go on with this grief years later. And maybe we need to talk a lot more about how men process grief when it comes to stillbirth, something we don't talk about. And I hope that's a discussion we can have as journalists and really tell these stories about how men really process grief when it comes to stillbirth, because we women can gather around and hold a party and really cry our hearts out, but men rarely talk about these issues, and we need to talk about that. But Gabby raises a very important question about, you know, just how people are pulling together and people coming together to offer support. Helga, how important is the power of partnerships when it comes to dealing with preterm?
Thank you, Mercy, and thank you, Gabby. So I think the most important here is that to realize that this is not a moment, this is a movement. And for that movement to really materialize, there is no time to lose, and all stakeholders are needed. Government commitments are needed. We also need parliamentarian action. We need healthcare professionals to understand and also and their skills. Private sector is needed, young people are needed, and civil society are needed. So investing in prevention of care or preterm yields substantial returns on investment. And healthy beginnings result in healthy progress, not only for the individual, but also for family, society, and the nation. And as Tanzania, as new investment, a case on small and sick newborn care, done with conservative estimates, has outlined a return of investment on 7 to 12 times. This is really good investments for not only rights, and not only for development, but also for economic so Dr. Salim who is with us here today, can also speak to this point. So it is not so much about investments, more investments, but smarter investments. Facilities must be built smarter. Healthcare workers must have the right skills, the right equipment, the enabling policies and environment. And this does not necessarily cost more money. It just costs better use of existing money. So we need social protection also for families of preterm and other sick babies. Families can be bankrupt by healthcare. And so these are huge costs and lost employment as they care for their preterm newborn. Another important thing is priority must be given also to education of adolescent girls, including comprehensive sexuality education. Young maternal age is a risk factor for preterm birth. So investing in education can reduce child marriage and teenage pregnancy. Both have a knockoff effect on reducing preterm birth. So this is really important. Investments need, as we've heard from Dr. Lon, that need also priority for women and children in climate mitigation and adaptation strategies. Also, what is important is we also need better data. As what gets counted counts. If not, it remains invisible. So leadership at the highest level is needed, as well as strong and empowered grassroots movements. This was a winning formula with tracking HIV/AIDS in the early 2000s. We need similar level of ambition here. We need heads of state standing up for the most vulnerable citizens, women and newborns. And we need future support civil citizens, women and newborns, in recognizing their partnership. So civil society, especially parent groups, Gabi, you are so needed here. And we have seen other examples in this conference that are really critical. Women groups need to also be in there with advocacy to ensure that this does not remain a silent emergency. We're back to you, Mercy.
Thank you, Helga. And I can see there are questions coming in. Fast and furious. People are in need of a lot of information. So please prepare yourselves to answer these questions. And now here, just to let you know that there's a question coming in from Sub-Saharan Africa, which I will let you answer after Bo comes on. But Bo, I would like you to talk about, you are an expert in many things, but we cannot leave this table without talking about respectful care, quality and respectful care.
Yeah.
Please.
Yeah.
How do we address that? How do we talk about that? Because like you've heard Gabi say, she was sent home. She knew she had a problem, but she was sent home. How do we get to that point where when I go to Professor Joy, as a woman who is pregnant, who wants attention, she understands that I may not be a medic, I may not be a gynecologist or a pediatrician, but at least I know my body. I know when something is wrong, and really be able to address that.
Yeah, it's so important. Thank you for bringing this up. And it really stretches over the whole kind of continuity of care in this reason. It is from before the pregnancy, during the pregnancy, the child when it's born, following up. So it's really the respectful care that is needed with this perspective. And one of the good things with our Born Too Soon report is that we have brought that in. We have a whole new section, a whole new chapter 3 in the Born Too Soon report that takes up that. So I come from the perspective of the women's health here and the women's perspective. And that starts before pregnancy. And the pregnancy and family planning should be offered to everyone. And then after and during pregnancy. So all these kind of things that we can do to change the flat line that Dr. Lawn have just presented here. It is pretty much that what is needed to do during this phase or in the society, as we have heard here. We have done many kind of achievements over the last decade, and there is much more to do. And we need to focus on the attention of the prevention and providing all women access to a comprehensive set of high quality, respectful service for sexual and reproductive and maternal health to women and also for newborn after adolescent when the baby grown up. It's a really important issue, both for women and boys here, of course, and girls and boys. And in the Born Too Soon report, it calls out every stakeholder, every partnership to take action on this. And we stress that we should do it in a multidisciplinary care provided way. It is in a partnership with women and a partner, and seize the opportunity of recent increases in the coverage of women's sexual and reproductive and maternal health care to improve the quality of care. Not enough to have the numbers of a visit. It needs to be quality of that. It should be also evidence-based, and it should be before, during, and after childbirth. And the antenatal contacts offer a critical opportunity for this that we shouldn't let. We should really take the possibility. We ask that proven tools known to improve the prevention and management of preterm birth, including the appropriate use that have been very clear over the last decade, that antenatal corticosteroids for women with threatening preterm delivery really have the antenatal corticosteroids. They should have it. That had been a question. It had been clear during this decade. So it's very important that we do that. So we demand that all women families receive respectful, person-centered care, that women and adolescent boys are respected. I think that it's very important that it's person-centered care for this, that what is needed. Go to the future. Whilst great strides have been made in providing technical guidance for preterm birth management, it's important that we work out more advance of our knowledge to better understand why the delivery starts too early. There is still no known risk factors for 2 of 3 preterm birth. 2 of 3. We don't know why it happened. And whilst we have the tools, there is need to further understanding how we will be best to implement that, and also to be able to predict the preterm delivery. We have a lot of studies in the world going on this, but it's difficult because preterm birth is a kind of syndrome of syndromes. There are many different reasons behind it. Time is the essence, and we need to work together. The whole conference here in Cape Town right now, it's really over the theme together, work together to ensure that every woman has access to high quality, reproductive and maternity care, and that every baby born too soon, and also the vulnerable newborn that are, I mean, for the pediatrician, it's not even, it doesn't matter if it's too soon, it's the vulnerability that is important. And of course, preterm is part of that vulnerability, can survive and thrive and grow, and taking care of the life circles when this baby is going to the teenage, being a teenager, and we take care of the adolescents. So thank you very much for highlighting this.
Thank you so much, Bill. And please allow me to go to the questions, because I feel like we're running out of time. The questions are so many. And I'll start with you, Joy, and Nahir. 3 questions from Sub-Saharan Africa. Everybody is interested to know what the data or the figures look like for Sub-Saharan Africa. There's Nancy Agutu from the Star Kenya. There's Naftali Muigai, and there's one other person who are asking, what does it look like for Sub-Saharan Africa? What are the rates? Very, very briefly.
Okay, well, first of all, I can give you the big picture, but I'm happy also to discuss afterwards with you to share with you the rates and the numbers and the rate of change for your countries. We have that from the UN data. So Africa, 4 million babies born too soon each year. The rates are higher than Europe, but actually just slightly lower than South Asia, so around 13% of babies, so higher than the 1 in 10. But I would like to flag that Brazil and in fact the US have rates that are not dissimilar to African rates. So the big difference for Africa is the survival, and Mercy kindly explained my gap better. So for babies who are born too soon in Africa, they die too soon, and this should not be acceptable. So I don't know, can I pass to Nahia to then say what to do?
Yes.
So because we are at a different position to 10 years ago, we have lots that we can do, and Tanzania is really leading the way. Thank you, Nahia.
So Nahia, what are the interventions that we need to put in place or that we need to copy maybe from Tanzania?
Thank you, Mercy. Thank you, Professor Joy. As you said, survival of the newborns is a bit complex, especially in sub-Saharan Africa. And we have seen governments investing, and Tanzania is giving a good example to that. How can we invest? This is a big question. And I think Helga said very nicely, we need a smarter investment. How can we be smart enough to invest? We understand that our health system is still weak in most of our sub-Saharan Africans. And Net 360, in collaboration with WHO and UNICEF, has just launched an implementation toolkit to support countries to implement in a smarter way. And how can this be happening is to strengthen our health system building blocks, harmonize our partners to work together through strengthening the newborn care at all levels. So we understand in most of the sub-Saharan Africa, especially in Tanzania, most of the deliveries happens in the lower primary healthcare centers. So essential newborn care should be key, emphasized, and going up to the higher level, level 2+, and to the tertiary levels. And we, for example, in Tanzania, we are creating a hub and spoke model because networking the facility is key. You don't want to miss that newborn from one facility to another, or even to the community level. It's essential because you want to capture the quality care through all the levels, taking care of these small and sick newborns. So referral system needs to be strengthened, and also where we are delivering our babies, this is where it starts. Especially now that, for example, in Tanzania, 83% of our birth happens in facilities. So we really need to strengthen that part.
Thank you very much, Nahia. And ladies and gentlemen, there's a gentleman who just walked in who we cannot allow to leave this conference without saying something, because I mean, he is the World Health Organization. He needs to tell us what they are doing to help countries really navigate this. Dr. Anshu Banerjee, the most wanted man in this conference. You've been he's been up and down, just really dissecting issues around maternal and newborn health, and really, really nice to have you here. And allow me to put you on the spotlight with this mic. And I'm really keen to know what the WHO is doing, to just hold the hands of countries as we navigate all this. What support are you giving us, and what support should we expect from the WHO? We're going to hold you accountable in 2 years, right? Please, you can speak as well.
Oh, I can just speak. Thanks very much, and a pleasure to join. Sorry, I'm a bit late. I was in another session. First of all, I think just looking at the mandate of WHO is really about providing evidence and guidelines. So we came out a few months ago, last year, at the end of last year, with the latest guidelines on preterm birth and low birth weight, with a number of recommendations, new ones and old ones that were updated. The next step then really is to see how do we implement that? How do we get that into national guidelines, and how do we get that into programming? And I think that was exactly the point you were highlighting, is that, how do we make sure that we change our health systems? So on the one hand, I think it's very specific in the sense of highlighting which interventions are needed. But on the other hand, we also have larger policy issues that WHO takes forward at country level, and that's how do we actually integrate these kind of interventions into a universal healthcare package. What are the essential interventions that need to be supported by the government that shouldn't result in financial implications for families, that should be accessible? We know that equity is a large issue, and we know that, for example, there's not only an issue between equity between countries, but even in countries. We have inequities between rural areas, urban areas, but also between different population groups when we look at income level or we look at educational status, etc. So there are many different factors to be addressed, and I think it's really looking at that systems approach in how do we make services accessible for the most vulnerable populations, and within a systems approach. And for that, for WHO at the moment really means that we need to reorient our health system much more to a primary healthcare approach. That means that we know that 80 to 90% of our interventions can be delivered at the primary healthcare level. And so that shift to make sure that services are coming closer to the people, that are allowing us to identify issues much earlier on so that our interventions can be more effective, and thereby also prevent the more difficult complications that are normally treated in a tertiary hospital, will first of all improve care for mothers and children, at the same time also reduce cost for the government, for the ministries of health, and make that funding available to provide much more services at the primary healthcare level. So that's a big direction WHO is taking, and that we are supporting member states to do. So I think it's twofold. One is really the specific technical work around maternal and newborn health, but at the same time, it's having that dialogue within a larger health systems context. We know that we have a health workforce gap. And so how do we work with ministries to make sure that the health workforce gap is also filled? That will also improve quality. And I think the other point, most likely already mentioned, is really, we know that there has been a major shift towards institutional deliveries, but we have seen in a number of countries that that didn't result in a reduction in mortality. And that is because the quality of care was not sufficient, was not good enough. And so really making sure that the quality of care is provided, and that is provided in a respectful manner, that people don't come to health services as a last resort because they feel that they will be blamed or shamed or not treated well. It's another component of quality of care that we really need to take forward in order for people to feel comfortable and to come early to health systems, to health services.
All right, just very briefly, I have had you talk about two things. What do you call the NF and the APMM? The end
And the
newborn action plan, and then the one for the maternal
and the
maternal. Yes.
mortality.
You have talked about those two things so much. Where does preterm birth fall in that? Because I realize it's a big deal at the WHO. So where does preterm birth fall in all this? Because we cannot talk about the mother and the child separately.
So what we are really highlighting, and that's part of the conference, and we're going to talk about that actually at the next session at the conference, is really we have highlighted these targets 90, 90, 80, 80. And we think that that's a crucial issue to take forward, because it is difficult to talk about mortality targets at a subnational level, because you don't measure them frequently. And so what you do measure is service coverage. And so what we say is that it's important that every district achieves 90% coverage for antenatal care. That is something that the district health management system can plan for. That's something that the district health officer can be responsible for and can be held accountable for. So similarly for postnatal care. And so we have set targets, specifically when we talk about small and sick newborn and the preterm baby, is that, you know, ideally every district should have a small or a special care unit for small and sick newborns with the required equipment, with allowing mothers and babies to room in together in order to be able to provide interventions such as KMC immediately after birth, in order to be able to provide the necessary antibiotics if needed, or oxygen if needed. And so this is really an area that, you know, we as INAP EPLN feel that we can support countries in taking forward.
Thank you very much. I'll only take one more question. I'm sorry, guys. Then please feel free to forward all the questions. And we've noted down everything that you are asking for. What we are going to do is Kathy, my amazing friend and colleague who's doing everything media for this, will be able to match all the questions with the correct people, and they will come back to you. So feel free. I'm sure PMNCH has all your details, but feel free to leave your email or any other contact that you want to leave behind, and then they will come back to you. But so, mental health and preterm births. How are we able to take care? And this is a question that comes from a CNN. How much focus is given to mental health needs of patients who have gone through preterm births and losses?
Yeah, I think it's very, very important, and it's very important to follow up, and it also relates to the stillbirth questions very much, because but we need to really have a collaboration between the obstetrical part and the neonatal part together with social services in many ways to really support this, because it's so important. And one of the biggest questions is that is from the kind of an immediate perspective, but also in the long run of this. One of the biggest risk factors for having one preterm birth is to have another one. So it's the biggest risk factor. And we don't know exactly what the reason. We start to understand the genetics behind that. But we certainly know also that mental anxiety, depression is obviously related to preterm birth. Many of us have published on this, and it's a clear line on this. We need to improve there. And this quality care that we have been talking about here on both sides of the mother and baby, and treat them together, it's so important. And also in a situation with stillbirth, I heard Kathy's story here, Gabby's story here, and it's so moving when you hear this, that you really need to bring it together, and also with the partner, how important it is. We need to improve in taking care of it.
Thank you very much, Paul. You know, so one of the parents told me that she's had 2 preterm babies, but every time she went back for clinic, the nurses, everybody was like, oh, how's the baby doing? But nobody asked, how are you doing? Helga, we have to close this. So please, can you give the final remarks, and then we can close this, because yeah, we're out of time.
Well, I was hoping you were going to answer the question that came to you.
On culture?
Yes.
Okay, I'm happy to it.
Yeah.
So we have been debating about
Yeah.
this, and somebody asked a very pertinent question. What is the role of culture when we're addressing the issue around preterm birth? We come from societies where preterm birth is looked at as a taboo. When you give birth to a preterm baby, everybody's questioning the mother. There's something wrong with your body. You're not doing something right. So why do you have such a tiny baby? You are cursed. There's so many issues that are thrown at a mother and the family that has given birth to a preterm baby. So what is the place of culture in this? I think we have a lot of, we need to demystify a lot of things. And I'm so happy that maybe I'm sitting here as a journalist, because that is where now the role of partnerships coming and the role of the media coming, because we need to tell people that it is not abnormal.
Yeah.
Yes, I mean, like, people give birth to preterm babies. So what we should be working on right now is how to make both the mother and the child thrive, and not look at this like something that is taboo. But also for you as researchers, as academics, as people who are bringing us all this data, then we also need to look back and look at culture. Like, how do we now get in here and be able to do advocacy from here? For example, I went to South Sudan, and there's this very big movement of kangaroo parenting. I like calling it kangaroo parenting because it's both mom and dad, not kangaroo mom. So kangaroo parenting, or however you'd like to call it. And the nurses, like, you need to do kangaroo parenting, the men, without realizing that in that culture, it is taboo for the man to hold their female girl as closely as, And without understanding that, you cannot be able to sit down with this person and really explain these issues. So really important to look at culture, but also one in a way that we can demystify the ones that aren't working, but also approach these in a way that also upholds the culture and doesn't make people feel like their culture is wrong or out of place and all that. So I guess that's how I would answer it. Anyway, Telga, will you please now close for us?
So much. Yes, thank you. And please, partner journalists in this quest of really important movement, please help demystify this issue. It is such a reality, and it is so bad to experience a stillbirth really in itself, and having it be a bad taboo in addition is such a double burden. So please, needs more attention, it needs the faith, and it needs data. It needs to be really something that gets counted so that it counts. And this is something that WHO is helping with, and all of the countries need to be adopting this on their national plans and also their budgets so that it becomes visible. We in the partnership are going to really try to do this with all of our constituencies for civil society, young people, academics, healthcare professionals, and really to amplify and get commitments and all of our partners committed to following this up. So let's make commitments, let's hold each other accountable. And that's the way that we don't need to sit here after just a couple of years and look at the trend still plateauing. We want the trend to actually go down. We would like to fight for that, and please help us to create more attention on this and play your part. Thank you.
Thank you very much. We have run out of time, but there are journalists here who I did trickle down. Anybody with a question before we wrap this up? Oh, wow.
Hello, everyone.
Hello.
My name is Leon Lidiku from the Daily Nation in Kenya. I'm a health and science journalist. So I had Mom talk about a crisis in cesarean sections. And I just wonder to Dr. Banerjee, I think at this conference I keep on asking this question. We never have conversations on how to hold doctors accountable because they are part and parcel of the structure that scares women away from accessing hospitals as well. How do we hold? Because, like, for example, in Kenya, cesarean sections have become a lucrative business. We have hospitals that have KPIs of attaining 80 cesareans a month, 60 cesareans a month. What is the WHO doing to protect patients from such doctors? I had both talk about a person-centered care. We have mothers who are living with disabilities. I didn't see them. At least next time we break down. I recently met a mother who was born and got polio at a young age. She works on all fours. She tells me she prefers the village midwife because whenever she goes to a hospital, there's not even bed that is custom made to fit her. She sleeps on the floor. She delivers on the floor. There are those persons living with disabilities that we never talk about. There are mothers who are born blind. They don't have some sign language interpreters in the local community healthcare facilities. They have given prescriptions they can't understand. We never talk about them, so they prefer to remain at home other than go to the hospital. How are we going to also remember them? For example, in Kenya, we have like 3 million people who are disabled, and of these are mothers. Thank you.
And Sharon, what do you think?
Yeah, we addressed this question earlier this morning as well with you. But maybe to add to what Queen was saying, I think there are 3 things that are necessary. One is that we need to make sure that deliveries are delivered through an interdisciplinary approach. So that means we need to have the right kind of health workforce there. We had a pre-conference symposium around midwifery. Midwives play an important role. So I think one is that interdisciplinary approach with the right kind of skill sets by different people, and to also have a clear distinction in roles and responsibilities for the different cadres between nurses, midwives, doctors, gynecologists, neonatologists, pediatrician, etc. So that's one. So the second one is to really look at setting targets and looking at targets so that institutions themselves can monitor whether they are going beyond the average that we anticipate that, would be normal. So normally it's between 10 to 15% of deliveries should have a cesarean section. Having too few is also bad, because that means that there are a number of mothers or babies who are not being supported properly. And too high is also bad, because that means that we're doing unnecessary cesarean sections, which have, of course, potential implications for infection for the mother, higher costs for healthcare, etc. And then the third thing, of course, I think a link to that is really having good accreditation and personal, let's say, continuous development of healthcare workers, so that they are, and to have mentoring, so that people can be mentored on what they're supposed to do. We can see whether their skills are up to date and whether they are providing the right kind of services according to, let's say, the right kind of algorithms to take decisions.
Just want to briefly flag that in the report, we have a box on this, and it's really critical. And as Anshi said, we want to tackle it at all levels. So at the top level, I think tracking C-section rates and questioning them. And in fact, California has reduced their C-section rate by doing that and holding public health accountability and reducing, and importantly, they educated women as well as workers, so women knew their rights. They had a campaign called "A Healthy Baby is Worth the Wait," because maybe people feel it's better to schedule something or whatever, but so that really helped. I think the financial incentives are critical, especially in the private sector. So I lived here in South Africa, and the private sector, some of the clinics near here, it's 80%. Bangladesh also has that problem. So we need to specifically look at incentives in the private sector. And then I think another point here is peer pressure. So obstetricians and especially midwives, if they're in the lead, can help to address this. And we would encourage you to cover this. And if you want more data, we can share more data.
I also follow up. I think that when in the board to Zoom, we are very engaged in this, because we also know that cesarean section is related to preterm delivery as well. It's one of the risk factors, one of the drivers that makes pregnancies. And one way to really work with this as well is to promote normal good delivery, and to go that direction is a possibility, and the benefits of that. We have strong evidence to support that, all the benefits of a normal delivery in those cases. So I think that's very important. Can I also address your second question?
Yes.
And I think that is one of the key issues, and that we really need to address it. And we have in the Born Too Soon report really highlighted this with human rights and also respectful care, with a whole chapter on this, to really highlight, and especially in the fragile and exposed settings that women are, as you described. It's horrible to hear about this. All women should be able to receive respectful care when they comes to the health service unit and delivery ward to deliver their child. That should not be. That is one of the main topics that we want to promote with this report.
Thank you very much, everyone. We have to end this here. Please, if you need any of these, lady, yes, there's a question. Yeah, sorry, because Nancy is here. So please allow me to close this. Then we can remain here. The experts will be here, and we can take the questions from here. Please feel free to bid for any of these people. Anshu, please go ahead. Anshu is leaving because he needs to attend to other conferences. Thank you, Anshu. So please bid for any of the experts that have spoken here. Send your questions, and they will be addressed, if you're not here, to Kathy, and she will match you with the right people. So thank you all so much for coming, and let's go and tell the stories of preterm babies and their families. Yeah.